Welcome to Bridges to Health and Healthcare. On behalf of Fort Drum Regional Health Planning Organization and North Country Initiative, thank you for watching. We are pleased to be able to offer this internationally recognized training to our partners, in part through the support of a generous grant from the U.S. Health Resources and Services Administration Northern Border Regional Commission, and we hope you'll find it worthwhile and useful. We intentionally offer this training virtually on demand because we know the time constraints that you face. This is often presented as a full day or multi-day training, and we have condensed it into about 1 hour. Whatever your familiarity with Bridges Out of Poverty, we hope you'll find that it aligns with and complements other initiatives your practice is already doing, including patient-centered medical homes or PCMH and value-based contracting. This presentation will feature the perspectives and voices of myself, Joanna Loomis, along with my colleagues Tim Fayette and Heather Petrie. So what is Bridges to Health and Healthcare? It is a set of strategies based on the Bridges Out of Poverty body of work, or Bridges for short. The Bridges model has been around for about 25 years and has been utilized throughout the U.S. and internationally. Simply put, you can think of it as a training in economic diversity. Within the context of healthcare, the objective of the training is for each of you to answer the question, how can we meet the healthcare needs of low-income, under-resourced people in our community? And what win-win side effects might our practice or organization realize by doing so? This training is intended to generate action items for you to take within your practice or organization. We encourage you to have a sheet of paper or draft yourself an email or Word document to jot down answers to the following questions. First, what policies or procedures does your organization already have in place that align with Bridges concepts? And second, what actions can you take or bring to your leadership team to consider that would promote this work in your organization? One thing we'll very quickly point out is that Bridges is not a program, but more a set of strategies and a lens through which to view economic class. Different economic classes exist, and for simplicity's sake, we can think of them as broken into 3 main groups: poverty, middle class, and wealth. Each class brings with it an environment and a set of what's called hidden rules for how people within it think and act. We'll get into hidden rules later. No one class is necessarily better or worse than the other, just different. And observations about the classes are not meant to be definitive or stereotypical. Instead, they're meant to be helpful generalizations and patterns. Bridges rests on the notion that if we can better understand each class, it will give us a common framework and language by which we, as members of different classes, can talk about economic class. The end goal of Bridges is to have representation from every economic class at the decision-making tables in any given community, and to create an environment where everyone, regardless of economic class, can live well. By the end of this training, you'll be able to describe how health and economic class intersect, better understand patients or clients from different economic classes, gain a definition of poverty that might be different from the definition you currently have, describe at least 4 types of causes of poverty, describe what hidden rules are and how they can impact health and healthcare, and have at least 3 action items that you can take in your organization to promote this work. By the way, if you haven't gotten out your piece of paper or started a new Word document to take notes and write down your action items, now is the time to do so.
Health determinants versus health expenditures. On the left of the screen, we can see what is driving our healthcare cost. On the right of the screen, we can see where our healthcare money is going. It is obvious that there is a mismatch in where our money is needed and where it is being spent.
The high cost of medical care in the United States is one of the greatest challenges that this country faces. Health affects everything from the individual's behavior to the broader economy. The U.S. spends the most on health care, but still has the lowest life expectancy and the highest rate of people with multiple chronic illnesses. Overall, health spending in the United States increased 2.7% in 2021 to $4.3 trillion, which is over $12,000 per capita. We know that 80% of health outcomes are shaped by social determinant of health barriers, but yet we can see where our money is being spent, and that is in hospital care, physician services, prescription drugs, nursing care facilities, home health care, other personal health care costs, government administration, net cost of health insurance, and government public health activities and investment spending. National findings align with research conducted much closer to home. Fort Drum Regional Health Planning Organization and the North Country Health Compass Partners recently conducted the latest 2024 annual community health survey and found that people with lower annual income and those with Medicaid or who are uninsured are more likely to indicate challenges in accessing various healthcare services. People with Medicaid and uninsured are more likely to say they have less than good mental health, as well as barriers with scheduling dental services. The 2024 Community Health Survey asked individuals in Jefferson, Lewis, and St. Lawrence counties how often they feel their provider respects their values. We can see how providers impact preventive measures and possible health outcomes and diseases. Patients who felt that their values were respected were more likely to receive a colonoscopy and mammogram than those who felt that their values were not respected. We can see that respect goes a long way in healthcare. When patients have a relationship with their provider of mutual trust and respect, you will see a return on investment. You will notice fewer no-shows. You'll be able to maximize your patient volume, which will increase your revenue, higher staff satisfaction, which will decrease the turnover rates, higher patient satisfaction, higher Medicare star rating, which will also increase your revenue, better prevention and treatment of chronic and acute illnesses, which will result in higher quality scores, and lower readmission penalties, which increases your value-based program performance. The Triple AIM is a framework developed by the Institute for Healthcare Improvement that describes an approach to optimizing health system performance. This framework indicates that new designs must be developed to pursue all three dimensions, which are called the Triple AIM. Improving the patient experience of care, including quality and satisfaction. Improving the health of populations. Reducing the per person or capita cost of healthcare. Bridges concepts and constructs intersect with the Triple AIM by offering an economic lens to improve the patient experience for patients from diverse resource sets, increasing social coherence, and designing services that meet the needs of patient populations that might not be identified with the stable resources of the middle class. These are hidden expectations of most service models. Act as an add-on model or lens to enrich the good work already being done towards reducing costs, lowering admissions, increasing patient treatments, and improving quality of care. This is an investment in people. Results achieved at Ellis Medicine. Ellis Medicine incorporated Bridges' key concepts and constructs. An accurate mental model of poverty gave an understanding of challenges and needs in the community. They found that many in their community were underinsured or uninsured. By focusing on the Bridges mental model of economic class, they were able to understand experiences of individuals of poverty in their community. Ellis Medicine improved its standing in the Robert Wood Johnson Foundation's ranking of healthiest counties in New York for 3 consecutive years. The percentage of uninsured patients treated at Ellis Health Center Emergency Department declined from 20% to 18% as the hospital enrolled most patients in Medicaid. The patient volume at Ellis primary care clinics increased 25% over 2 years as patients increasingly visited clinics rather than the emergency departments. More than 340 people without primary care physicians established care at Ellis Family Health Center.
Bridges work is intended to be used at 4 levels: individual, institutional, community, and policy. We call these the Bridges lenses through which you can view your customers, organizations, communities, and policies and use the Bridges information. Everyone will have their favorite lens or ways they like to view the material. For example, some of us spend 98% of our jobs working with individuals, so when we go to a training or receive new information, we are asking, now how do I use this information when I'm working directly with a person? The Bridges individual lens will give you specific tools that will assist you with this level. As a person gets promoted, their favorite lens often changes to that of the institutional lens. Now, when we receive new information, we are not thinking about how we use it at the individual level, but rather how we can use this to change the way our program is set up and adjust how our institutions operate. The institutional lens will give you concrete methods and ideas of how to use the Bridges informational at this level. Some of us consider ourselves community advocates, and we want to know how we use this information at the community level. There are communities throughout the country and in other countries using Bridges information, and they are happy to share strategies. The community lens will give examples and ideas of how to use Bridges at the community level. If we use the Bridges material at the individual, institutional, and community levels, then often we run into barriers that can only be solved at the policy level. This includes the policies that run your program and goes from the local government all the way up to federal policies. The Bridges lens allows you to understand why, as a provider, you need to maximize the opportunity you have when you are in front of a patient. Sometimes this can be an entire philosophical shift. I challenge everyone to view this training through lenses other than your favorite as we go through the material. Bridges defines poverty as the extent to which an individual does without resources. This helps us understand that poverty is about more than just how much money you make. We can switch out individual with institution, community, town, and so much more. When we talk about poverty, what else can we talk about besides money? What resources determine whether a person is in instability or stability? Where do resources come from? From the unique qualities of each person. Many resources are passed along from parent and family, as well as through friendships and connections. The community is also responsible for developing resources that create growth and a nurturing environment. As we work with people, it is important to understand the resources of the patient. So what are these resources? Resources are interconnected, and strengths in one area tend to lead to increased levels in another. Physical health can influence emotional health. Cognitive reasoning can influence emotional stability. When thinking about resources, the Bridge approach is to focus on assets rather than deficits. In other words, we use a strength-based approach. So originally, Bridges Out of Poverty started with 9 resources, but through the interaction of Getting Ahead graduates, they asked to remove coping mechanisms, and as you can see, language is highlighted yellow. They added language, integrity and trust, and motivation and persistence. So as you can see, the first one, financial, having the money to purchase goods and services. Next, we have emotional, being able to choose, control emotional responses, particularly to negative situations without engaging in self-destructive behavior. Mental, or I like to say cognitive, having the mental abilities and acquired skills, reading, writing, computing, to deal with daily life. Language, having the vocabulary, language ability, and negotiation skills to negotiate the environments necessary to build resources. Social capital, includes both bonding capital, connections with people similar to yourself, and bridging capital, connections with people different from yourself, keeps one from being socially isolated. Next, we have health. Any health problems you have are managed and do not interfere with your ability to work and be self-sufficient. You have access to culturally competent healthcare providers. Moving on with the other resources, On the top, we have spiritual, believing in divine purpose and that you are part of something larger than yourself. Next up, integrity and trust. It's highlighted in yellow. This was one that was added by grads. Having the ability to keep your word, honor the laws that govern you, and make decisions based on high ethical standards. It is equally important to be able to trust others to act with integrity. Also, motivation and persistence, another one that was requested to be added. The energy and drive to prepare for, plan, and complete projects, jobs, and changes. These are connected to resiliency, the willingness to try, and the courage, stamina, and fortitude to work towards a goal. Up next, we have relationship role models. Having frequent access to adults who are nurturing and caring and do not engage in destructive behavior. Having friends, family, and backup resources available to access in time of needs. And lastly, knowledge of hidden rules. Knowing the unspoken cues and habits of a group. While these resources are needed to get out of poverty, these are also needed for stability in any setting, whether you're middle class, an organization, or a government. Next, we'll be moving on to discuss the different causes of poverty. But before we do that, I want you to ask yourself, if your providers understood each patient's resources, how might the healthcare delivery outcome be improved? Also, does race or income seem to matter equally?
We've learned an alternative definition to poverty, which is the extent to which an individual does without resources. So, what causes individuals to lack in various resources? There are 4 overarching causes of poverty. On the right side of this chart, you'll see political and economic structures. This could include factors like how your state or your country define minimum wage, how businesses are regulated, whether your state or country provides social services, what kinds, and at what levels, etc. Exploitation is another cause of poverty. This examines how policies or business practices take advantage of individuals or communities. An example of this could be exorbitantly high interest rates on credit card debt, or car dealers that offer you a car to drive away without a down payment, but that come with very high interest rate loans, or rent-to-own companies that provide you with a bed or a TV, etc., but for which you're charged a monthly fee over a long period of time, meaning that you end up paying way more for the items than they're worth. These types of predatory practices take advantage of people who are looking for basic needs, but who don't have the money up front to pay for them, and essentially bury them deeper into poverty over time. A third cause of poverty has to do with community conditions. This includes factors that impact a city or a region, like the state of the economy, the quality of education, the presence or absence of affordable housing, and even things like whether there are safe sidewalks or trails for walking. Finally, on the left of the screen, you'll see individual behaviors and circumstances. While arguably the other 3 causes together are very powerful, it is nevertheless the case that individualized factors also contribute to people's economic status. This could include things like smoking cigarettes, for example, their financial cost and effects down the road on one's health, substance use, what type of education or employment someone pursues, etc. The great thing about this slide is that it offers a holistic view of the causes of poverty. Sometimes people's thoughts about poverty can be skewed. Sometimes we focus on individual behaviors only, and other times we focus just on political or economic structures. What Bridges does is acknowledge that it's actually all of these things and more. So let's start to apply the causes of poverty to healthcare specifically. What factors within healthcare either promote high-quality healthcare or, on the flip side, promote low-quality healthcare? In other words, what are the ingredients of high-quality care? The next slides will dig into these.
Access is the ability to enter or engage a healthcare provider, system, or resource. During these examples, ask yourself, how are our patients affected by these access points? Public transportation. Are your patients able to access public transportation to get to your clinic? Or is it an access barrier? Insurance type. Do you only take a certain type of insurance? Or do the people you're referring to only take a certain type of insurance? And does that decrease access for your patients? Insurance copays. Are your patients able to afford their copays, not only in your clinic, but when they go to specialty clinics and also their medication? Providers, type, number, and location. Do you have enough specialty providers in your area? Are they easy to access at a good location where public transportation is accessible? Appointment process. Do your patients know how to make an appointment? Are they able to make their own appointments for specialty clinics? Provider and agency policies. Do your policies support easy access, or are they deterrent to access? Contact information. Is your contact information easy to find for patients, or is it difficult? Medication types. Do your pharmacies in the area provide all the medications that your patients might need? Or is access a barrier because they only carry certain prescriptions? Availability is the conditions and time frame in which care is available. As we go over these examples, I want you to think how the ability or lack of ability will affect your patient's ability to receive care. Specialty providers and types. Do you have enough specialty providers in your area? Hours of operation. Are the available hours of operation conducive to those who work or even to the public transportation system? Location of providers. Continuity of care. Do your patients know who their provider is every time they come to their appointment, or do they have a different provider every time? Wait list. How long are the wait lists for providers in your community? Fragmentation. Referral systems. How difficult is it to refer your patients, and do your patients understand the referral system? Policies. If geography alone were a cure for poverty, that could have been accomplished many years ago. Without the social cohesion and collaboration that is needed, a change in where we live does not solve availability issues. In some cases, the lack of a robust public transportation system presents the biggest challenge. One of the common stories from ambulance services is the number of individuals from poverty who call the ambulance to go to the emergency room because they don't have transportation, not because of health issues or life-threatening issues. Cost. Actual cost, price charged, and fees for services. Let's look at the cost of certain items throughout your community for individuals. Where we shop for over-the-counter medications matter. Think about, are your patients getting their over-the-counter medications at a corner store, or do they have the ability to go to Walmart? That cost could be quite different. In addition to individual costs, there are also institutional costs, which may include unfunded emergency room visits, personal turnover, specialized equipment, competition for specialized physicians. There are also community costs to county and city governments, such as medical transportations like helicopter, unfunded ambulance services, and county hospitals. Think about, is the voice of my patient included in our services? Quality is the extent to which services provided improve health outcomes. The following are examples of quality and how they might affect the perception of quality for those you serve. Customer service, standards of practice, fragmentation of delivery, knowledge and experience of providers, competition among health systems, wraparound services, appropriate materials and explanations, quality assurance. Are health and healthcare a right or a privilege? How one answers that question directly influences perceptions about quality. Many times, perception of quality is equated to having options. Safety net hospitals, for example, are frequently viewed as primary destinations for the poor and uninsured who become ill or have a personal injury, while middle class and occasionally wealthy individuals might choose to go to safety net hospitals in the event of a trauma. Most insured patients opt to go elsewhere because they have the option. Disparities in perception of quality also show up in settings where care is provided with a limited formulary of drugs. The quantity and perceived quality of the medication may be called into question by those who believe that access to non-generic options may be better, even when that may not actually be accurate or true. Efficacy is the capacity to produce desired or optimal health outcomes at individual, institutional, community, and policy levels. Efficacy also includes social cohesion, collective knowledge bases, and understanding such as hidden rules, economy inequality, planning and use of time frames. It is the capacity of resources to assist in healthy efficacy. Each of us at one time or another has filled a glass of water too full. No matter how much we wanted the glass to hold all the water, it just could not. This is capacity. In the Bridges framework, we learn that in poverty, survival tends to be a daily challenge. A number of issues, or crises, occur at once. Resources are scarce, and the impact of those often lessen the resources available, leaving it difficult, if not impossible, to plan.
The following are strategies and tools used in communication. These will help promote positive relationships and healthy outcomes. Understanding that there are different registers of language, how nonverbals play a role in survival mode, mental models, planning backwards, mediation, information gathering from a story, and the role of voice. All too often, the information given by health institutions to individuals in poverty is only partially understood or not understood at all. There is a direct correlation between poverty and poor health.
Now we're going to take a look at a mental model of poverty and middle class. But first, what is a mental model? Mental models are our internal picture of how the world works. They exist below the level of awareness and are often unexamined theories in use. They determine how people act and interact and can help or interfere with learning. Mental models inform the way people think about individuals, institutions, communities, and policies. To have an accurate approach to the issue of poverty, people must have accurate mental models. For dialogue and solutions to occur in a group settings, we sometimes must suspend aspects of individual mental models. Have you ever had a family member who grew up in the Great Depression? What behaviors did they learn from the experience? Did they pass that learning along? What is the message or mental model of poverty from the Great Depression? How many of us could say, all right, Grandma, we've got enough rubber bands now, because there was a sense of needing to save, to conserve during the Great Depression? What mental models of poverty do you have? Here's a mental model of poverty or instability created by Getting Ahead investigators who live in or near poverty. The inside of the circle represents what a day in the life looks like of someone living in poverty. These are activities done throughout the day. The blue circle at the top represents the institutions people living with instability interact with on a day-to-day basis. Often people living in poverty spend a lot of time doing agency time. Agency time is when someone has to go from organization to organization and get the help they need just to survive. The bottom half are all the businesses you will find in an under-resourced neighborhood. Many of these businesses exploit those living in instability, and most of the time you won't find these businesses in a stable community. In the center you'll see relationships in big blue letters. Relationships are a driving factor and mean everything when living in instability. When other resources are low, people and relationships can help you get by. Living in constant stress and anxiety affects health and can become a trap. It is hard to look past the concrete, immediate concerns that pop up every day. Under-resourced communities are a risk factor. Tyranny of the moment is when the need to act overwhelms any willingness people have to learn. Time is a limiting factor for everyone. Everyone has 24 hours a day. The closer one gets to survival, the less time one has available to learn abstract knowledge bases. Meeting basic needs without the resources that enable long-term planning thrusts people experiencing poverty into what we call tyranny of the moment, where all available time and resources are focused on survival.
People struggling with poverty need to act on concrete, immediate problems all day. The feature of poverty results in a life in the tyranny of the moment, a time horizon of one day. This is why the change plans of the middle class organizations don't always make sense to people in poverty. People in poverty are solving concrete problems and usually don't have the time or energy for abstract or new learning. Sometimes it can be a matter of being reactive versus proactive.
Living in poverty and consistently being stuck in tyranny of the moment taxes the brain. This slide is based off of a study of sugarcane farmers. Farmers were poor and demonstrated a drop in IQ the closer they got to harvest season. Emily Badger writes, poverty imposes such a massive cognitive load on the poor that they have little bandwidth, a mental burden akin to losing 13 IQ points, coping not just with a shortfall of money, but also with concurrent shortfall of cognitive resources. This can impact a lack of nutrition, homelessness, the stresses from poverty, etc. Often in healthcare, as in any services offered to the poor, we are tempted to confuse slow thinking, seemingly flat affect or lack of responsiveness, with laziness or apathy. Could there be another possibility? This is a mental model of middle class that was created based on input from people in the middle class. We define middle class by the stability of all resources, just not finances. But for a household to be in the middle class, usually at least one person in the household must have a job that pays a living wage or better. Most people in middle class know that they will have food every day, and they know where they're going to sleep at night. The resources are stable and predictable. The driving force for decision making in the middle class is achievement, which often includes achievement at work and achievement in developing material security, owning a house, contributing to a retirement fund, things along those lines. Around the inner edge of the circle are the things people in the middle class spend their time on, and many of the items found in the mental model of poverty are found here as well. Childcare, healthcare, mental health and chemical dependency, family and friends, etc. The difference is the resource available to assist people with those issues. Communities of stability are a protective factor. The third area we will examine in some detail is illness and healthcare. People struggling with poverty in the United States have more health problems than people experiencing middle class or wealth. They also have more trouble getting health care. This slide introduces you to the SES, Socioeconomic Status Gradient. The gradient is very steep in the US. If you want to be healthy, you need to be wealthy. The richer you are, the healthier you are. The poorer you are, the sicker you are. Let's consider the link between illness and poverty. Do you know children in poverty who take care of sick adults? Do you know people who, because of the cost, don't go to the dentist or fill prescriptions or do preventive medicine, or who postpone visits to the doctor or put off having procedures done? Do you know people who have medical debt? In countries that offer socialized medicine, there is a less steep SES gradient than in the US, but the wealthy are healthier in these countries as well. The reason this disparity exists is not entirely due to access to medical care. There are many factors that influence one's stability, as we are learning today. Before we move on to take a look at the hidden rules, I'd like you to ask yourself, how might health and healthcare outcomes differ based on each of the economic environments? What resources are not available equally to all economic classes in your community?
Now that we've covered the mental models of economic class, let's look at the hidden rules of economic class. Again, not to stereotype, but to take a step back and look at patterns, you can conclude that each economic class has some hidden rules or unspoken cues or norms. These rules are often taught subconsciously. For example, imagine two families. One family always takes their shoes off when they step inside their home. The children in that family see this happen over and over and naturally come to also take their shoes off as well, as a habit. But another family wears their shoes inside, and consequently their kids do the same. What happens when kids from one family visit the house of the other? They will likely break a hidden rule. We'll examine some hidden rules of economic class in the following slides. As we do, think about what it might be like to be someone who has grown up in a poverty or unstable environment, who wants to move into middle class or a more stable environment. What hidden rules might they unknowingly break? Some could be merely embarrassing, but others, such as not wearing the right type of outfit to a job interview, for instance, may have more significant consequences. A few key points before we get into some examples of hidden rules. First, think of each family as its own culture. Each of us is like this rich piece of fabric that's very different from person to person. We have threads that come from our race, our religion, the region we grew up in, our economic status, gender, and other factors. Each of us brings with us a whole set of hidden rules. Oftentimes, we may not even be aware of our own hidden rules until someone breaks ours, or we break someone else's. How does this come into play in healthcare? Most schools and businesses, and arguably healthcare organizations, operate from middle class norms and values. We'll get into these in the next slides, but for now, let's say that one hidden rule of middle class is that you have to arrive at least 10 minutes early to an appointment. If you didn't grow up learning that rule, and if in your community or family culture you take a more relaxed approach to time, then you'll likely break this rule when it comes to your next doctor's appointment. Even if the office has signs hanging up or calls its patients to remind them that they have to arrive 10 minutes before their appointment, they're still likely to break the rule. Now let's take a look at a hidden rule related to something very everyday and common: the hidden rules of food.
The hidden rules about food are some of the best illustrations of how hidden rules arise out of environments, resources, and conditions. One of the areas we have hidden rules about is food. Food is very important because food is often the line between being destitute and merely being poor. The issue around food and poverty is quantity. The questions after a meal are you full? Did you have enough? Now, this doesn't mean poor people don't like good tasting food, but when you don't know where your next meal is coming from, eating enough is the priority. In middle class, people have too much food. There's always enough. They're always on this diet or that diet. So the issue around food is quality. The question after a meal are, did you like it? Was it good? In wealth, there is always enough food, and it is always good because you aren't doing the cooking. You may even have a personal chef. The issue around food is presentation. The question after a meal is, was it artistically presented? Did it have an aesthetic appeal? Did it go with the theme?
Hidden rules about time. The following are some examples of how individuals in different classes may view the rules of time. In poverty, the present is the most important. Decisions are made for the moment, based on feelings or survival. Middle class, the future is most important. Decisions are often made against future ramifications. In wealth, traditions and history are most important, and decisions made partially on basis of tradition or decorum. In middle class, the environment is stable. People don't fear for today. The time horizon is 2 to 4 years. The future is the primary focus. The present does not take all of your energy. It isn't about survival, but about planning and decision making to increase stability. Middle class needs to take yoga to remember there's a present. Another piece of that, in middle class, your future depends on your being on time for work and to appointments. Once you're there, it is expected that business will begin at once. Get to the point. This is accepted and expected. In poverty, the environment is unstable and unpredictable, so it forces people into what is called the tyranny of the moment. The time horizon is today. It's a struggle just to survive today. Decisions are made for today. Getting down to business without allowing time to check out what is happening in your personal life is considered an insult. This is the number one middle class hidden rule that people struggle with in poverty breaking. They are often late to appointments and work. It's important that we help people experiencing poverty develop a future story. One of the worst things about poverty in the U.S. is that people lose their future story. To end poverty, we must help people develop their future story. And wealth environment is so stable that people don't fear for today or the future. The time horizon can be 1 or 2 decades. The past is a strong focus. There's a strong sense of continuity, which emphasizes the past. You have been given a legacy from the past, and you will be passing along the legacy to future generations.
And finally, let's look at the hidden rule of destiny. Sometimes in poverty, there's a sense that things will just happen to you, no matter what you do. Choice can sometimes be trying to choose the better of two bad options. Energy is often used to put out fires because you couldn't stop bad things from happening. In the context of healthcare, there's a sense that whatever may happen to my body now or in the future is just going to happen. I always tell my personal story, which is that my dad advised me when I was young that it wouldn't be worth it to go to the dentist or take care of my teeth because my teeth, like his, would eventually fall out anyway. I'm happy to report that that didn't end up being the case, but it does give some insight into this hidden rule. In middle class, a stable future is linked to choice. The focus is on preventing bad things from happening. When bad choices are made, the resources are usually high enough to stop more bad things from happening. Think about college savings plans, or in the case of healthcare, establishing with a primary care provider and seeing them regularly, like for wellness visits or cancer screenings. The guiding thought here is that if we take care of ourselves now, we'll mitigate health problems down the road. And if cancer is in our future, we want to know as soon as possible so we can effectively treat it. In wealth, noblesse oblige means you're privileged and responsible for giving back to create a better world for the less fortunate. In a sense, you are fated to be privileged and give back. The resources you have are so significant and the choices so wide that choice really isn't the primary focus. How have you seen hidden rules play out in your line of work or even in your personal life? Take a moment to consider examples of hidden rules that you've seen in action. Now that you're aware of the notion of hidden rules, does this make you approach your work any differently? As we wrap up this section on hidden rules, let's acknowledge that one set isn't necessarily better than another set. In the context of health, getting and keeping good health requires significant resources. People in poverty are, by our definition, lacking one or more key resources. If you're working with a patient or a client to create a care plan or set goals, don't assume they have all the resources needed to implement them. Finally, use every opportunity to create trust and mutual respect by teaching the hidden rules of your institution in a respectful way to your patients and clients. The rules used in poverty at home or in the neighborhood may be different from the ones used by an organization, clinic, facility, or doctor.
We have made it to approaching the bridge. Now we will talk about communication, language, and cognition. The power of story in healthcare. How many times have we heard this? What happened was, why I didn't get my medication the first time, why I didn't get my refills, why I let my insulin run out, why I didn't get to the grocery store, why I missed my appointment, why I couldn't bring Junior to get his shots, why I missed my ride and couldn't get another. When individuals talk in circular story, it can be easy to miss important information. Oftentimes, these stories begin with what we just heard. What happened was, why I didn't. But there's such rich and important information in these stories. It is important to pay attention and ask questions.
All languages have 5 registers of language: frozen, The language that is always the same. Think of prayers, of vows, and medical terminology. Formal. The standard sentence syntax and word choice of work in schools. It has complete sentences and specific word choice. It is usually written. Consultative. Formal register when used in conversation. Discourse pattern not quite as direct as the formal register. Casual. Language between friends. Word choice is general, not specific. Conversation is dependent on nonverbal assist. Intimate. This is the language between lovers or twins. It's also the language of sexual harassment. The formal register of language is used to negotiate in organizations, businesses, courts, medical facilities, and schools. All registers have power. Speak formal register in a poverty neighborhood and you will likely be in trouble. Formal register does not have power in that situation. Our organizations can use mental models, high-frequency words, videos, and stories to communicate. The first thing when someone enters our office, fill out the paperwork. Using the formal register to negotiate nurtures one's ability to think abstractly, to hold concepts inside the mind. Middle class is about paper. People in generational poverty tend to utilize the casual register of language to survive. Casual is more accurate for reading someone's intent. In poverty, several people live in one house, so you have to know what is safe and what someone's intent is. In poverty, you must attend to sights and sounds to survive. In poverty, your world is often about processing the external environment. Because you are processing the external environment in poverty, nonverbals become crucial, and you begin to expect and read them. The language you have access to is often about survival. Often one will process more heavily in the concrete. Also, paper does not have as much value. Middle class sounds noisy to those in casual registry. The key is to honor the register someone brings with them and to also build bridges to formal register. Communication problems create an imbalance of power. It's only when the power is relatively equal that candid communication can take place.
I see you, but I can't hear you. We almost always communicate with patients in formal register. Some patients, clients speak in casual register. Nonverbal communication is very powerful in casual register. In the medical community, we almost always communicate in formal and frozen register. For the caregiver, clinician, health worker, the statement may be, I see you, but I can't hear you. For the client, patient, the statement may be, I can hear you, but I also see you, and the words and the nonverbals don't match. Why is this so? What you say becomes blah, 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 or noise if I can't understand it. So what happens in healthcare settings when patients and providers do not speak the same register of language? You could see institutional inefficacy, and some examples of that are misunderstanding and broken relationships, delayed or inappropriate clinical interventions, medical staff that are often trained to only use the formal language, written communication without nonverbal assist, and these can lead to a lack of healthcare compliance. Client and patient outcomes become compromised. Lack of adequate vocabulary, sentence structure, and syntax knowledge lead to delayed or inappropriate clinical interventions. Client-patient outcomes get compromised in the absence of adequate or appropriate translation of both verbal and nonverbal communication. This makes take-home instructions a challenge. Much of the meaning in casual register is derived from nonverbal assist, not from word choices. Bracketing is an incredibly powerful tool to narrow a conversation, particularly when someone is in crisis or has multiple issues they are mentioning. It respectfully places control and power into the individual's hands for what area they like to explore together, while still maintaining accountability for the time you have together. This tool also helps break the issues down into small, manageable steps, placing others in the mental box so that individuals can take a breath, think, and focus.
Thank you for hanging in there with us. Now we're coming up to the final stretch of this training, Part 2, Courageously Crossing the Bridge. Let's examine how to fine-tune relationships of mutual respect when working with under-resourced patients and clients. We will discuss social cohesion concepts in order to design services and human interactions that result in reduced costs and an increase of quality of care. We will co-investigate the impact of social capital and discuss ways to link under-resourced patients and clients to positive social supports and resources to achieve improved treatment compliance. And lastly, we're going to practice seeing systems and interactions through the Bridges lens. First, we have the patient life cycle. Where do our patients come from? What do they need to go through to get into our institution? And what does our institution have those patients do? It's taking an honest look at what our patients and customers go through from the point of first contact to discharge. In order to be effective, organizations need all the people at the table, their patients and customers, frontline staff, middle management, and administration. The patient life cycle allows us to ask, what's our organizational culture? It also allows us to take a look at who's our initial contact. How difficult and time-consuming is our intake form? How long do patients wait for an appointment, to get a return phone call, or even just in the waiting room? It allows institutions to take a look at barriers that could come in the way of relationships of mutual respect. Next, we'll take a look at changing behavior versus changing rapport. What is your organization's theory of change? Every organization has one. Do you know what yours is? How much time does the agency spend focused on behavior change rather than on changing rapport? When change is discussed with patients, who does most of the talking and what is the person saying? Who's doing the change talk? Is it you or is it the patient? Everyone is motivated for something. What's important to you? This could be as simple as being more generous with a 15-minute window before canceling an appointment. Or am I finding reasons why the patient is non-compliant, or am I trying to find out the reason why they are and what I can do to help? A cohesive society works towards the well-being of all its members, fights exclusion and marginalization, creates a sense of belonging, promotes trust, and offers its members the opportunity of upward mobility. Social coherence in institutions is the development of social resonance between the system and the population groups and individuals the system engages. How can we do this? We can do this by decreasing noise and reframing health messages using mental models. Create relationships of mutual respect. Honor and respect different sets of hidden rules. Use mediation in adult voice. Design effective forms with feedback from patients, and quickly determine if the patient has the resources needed to follow the treatment plan you may have developed for them. Have you ever felt like the smaller person when someone is talking at you, telling you what you should, shouldn't, or need to do? You likely feel discounted and less than or separate from. When we truly have a relationship of mutual respect, then both parties are equally engaged in the conversation, providing information back and forth that is equally valued. We are fully listening to one another intently without agenda and not listening just to respond. Both parties feel valued and are engaged in the conversation without a predetermined or hidden agenda.
Bonding and bridging support for my change. Treatment compliance may depend on social capital. You could be the only bridging social capital available to the patients. One of the 5 major learning sequences in getting ahead has to do with the relationships one has. It starts in Module 5 with the key point that states that one might have to give up relationships for a period of time when working towards an achievement. Every person who gets out of poverty has to deal with this, and it's often a painful experience. There are several times that this idea is sequenced or reinforced. Each time is an opportunity for investigators to think and discuss their relationships. At the end, just after making their SMART plans, the investigators make a list of who they will have on their team as they pursue their future stories. As we can see, sometimes the individuals in our future story in our support group are not always who we think they should be. So think about, How powerful is the relationship between treatment compliance and social support of change? How are you building relationships of mutual respect? How could small changes have a positive impact on quality and cost? How do you support patients with low social capital? What are some ways you could collaborate with community partners to build social capital with your patients? This is a mental model for disease management. You'll find that mental models work very well for patients who are visual learners. The past, present, and future sections provide space to examine the present situation in detail and create a concrete plan for disease management for the immediate future. The information about the past also may have a bearing on the decisions to be made. The space above the line is to create the mental model illustrating the conditions in the patient's lives as to the relationship and the immediate problems they face presently. The mental model for the future represents not only the plan for disease management, but also the changes that are to be made by the patient in cooperation with healthcare professionals. The space below the line for past and present are to note significant information. The space below the future is for concrete plans and the steps that the partners will create and work on together. The circle beneath support team represents another mental model developed by the partners as they worked towards the plan.
As we come down to the end of the training, it's important to remember that Bridges Out of Poverty is not a program. It is a framework. It is a set of constructs that we can use to test if our programs and initiatives are truly bridges. Number one, use the lens of economic class to understand and take responsibility for your own societal experience while being open to the experience of others. Number two, address inequalities in access to resources at the intersection of poverty with other social disparities, race, gender, physical disability, etc. Number three, define poverty as to which a person, institution, or community does without resources. Number four, build relationships and mutual respect. Number five, base plans on the premise that people in all classes, sectors, and political persuasions are problem solvers and need to be at the decision-making table. Bridges constructs continued. Number six, base plans on accurate mental models of poverty, middle class, and wealth. Number seven, stabilize the environment, remove barriers to transition, and build resources at the individual, institutional, and the community policy level. Number eight, address all causes of poverty, individual, community conditions, exploitation, and policy. Number nine, build long-term supports for individuals, institutional, and community policy transition. And lastly, number 10, build sustainable communities in which everyone lives well.
As you've listened to this training, we hope you identified at least 3 action items that you can take. Your action items can be on an interpersonal level, an organizational level, or a community or systems level. Some examples of action items that your colleagues in the North Country have identified after past trainings include revising or eliminating their organization's appointment no-show policy, screening patients or clients for their social needs and working to address those needs through direct services or referrals, forming a patient or client advisory committee to get feedback from all economic sectors about their services, evaluating and lowering the reading level of signage or paperwork as needed, starting an organizational fund or applying for grants to provide patients or clients with gas cards or bus tickets to get to appointments or other needs, and expanding Bridges training to other departments. Thank you so much for participating in this virtual on-demand training. If you have feedback, questions, or want to ask about scheduling a future training, contact one of us using the information on the screen. Thank you.